Hello, today we shall have a quick session on Htlv associated infective dermatitis. And this is a condition that actually most of you are not aware, but it actually exists. And it is very key for you to know how it presents and what are the categories of patients that are affected. So we know that this condition or this infective dermatitis is one of the rare forms of dermatitis, or oftentimes seen in childhood and adolescence. And these are individuals that have been infected by the human T-cell lymphotropic virus type 1. And you know that this virus falls in the same category with the retroviruses that we usually see for HIV-1, HIV-2. So this is one of the viruses that can also cause skin manifestation. It causes the infective dermatitis. So it's a little bit rare, but it can exist. And you as a dermatologist, it is your role to know these rare things because they make you distinct from other people who are actually not dermatologists. So in the presentation, this eczema oftentimes affects the scalp, the axilla, and the groin, as well as the nose. So the patient will have a watery discharge from the nose, as well as a rash that can look like atrophy that covers the scalp, the axilla, and the groin. So how we know that it is an infective dermatitis? In this case, when you try to give any antibiotic, the rash will show a very prompt improvement, only to reappear after you have stopped your antibiotic. So this virus was first identified in the 1980s, and it usually infects the T cells, the B cells, as well as the monocytes. That's why they say it is lymphotropic. And primarily, it is transmitted through breastfeeding from mother to the child, but can also be gotten through sexual intercourse, blood transfusions, as well as needle prick injuries. So it is associated with other adult diseases like the adult T-cell leukemia and lymphoma. These are malignant conditions, but now in the children and in our adolescents, it can give rise to infective dermatitis, which can look like atrophy. So typically, you see it can also give a rise to the tropical spastic paraparesis or even infective dermatitis in the children. In the pathogenesis, there's a thinking that there's a dysregulation of the immune system, which leads to immune suppression, increasing the susceptibility to bacterial infections, especially the staph aureus and the beta hemolytic strep, as well as parasitic infections like scabies, and then also the strong laid ones. So there's a thinking that there's also a genetic factor contribution, and since it is oftentimes seen in places with a low socioeconomic status and malnutrition, there's a thinking that all these play a role in the development of this type of dermatitis. So when you look at its dynamics, more than 90% of carriers of this viral infection are actually asymptomatic. So they get the infection with the human lymphotropic virus, but they don't show any symptoms. That's 90%. And then the disease symptoms typically appear in adulthood, except for infective dermatitis, which can occur in childhood and adolescent period. But oftentimes, it comes in as a manifestation of cancer, where someone gets either leukemia or lymphoma. And we see that this virus usually induces a spontaneous T-cell proliferation and a production of interleukin-2 receptor or suppression or expression of interleukin-2 receptors, and also secretion of interleukin-2. All these are pro-inflammatory cytokines, as well as the interferon gamma, interleukin-5, and then also interleukin-10, which is usually inhibitory. And you've seen interleukin-5 as well as in atopic dermatitis, where it plays a role of stimulating T helper 2 mediated response. And in symptomatic patients, they usually have elevated levels of human process factor alpha, as well as interleukin 6. So this virus, once it has infected your lymphocytes, B cells, and monocytes, then it will make them produce these pro-inflammatory cytokines that are thought to actually drive the infective dermatitis. So in this case, when you look at where is it commonly seen, we find that most of the patients that are affected, that is 10 to 20 million people worldwide. The majority of them occur in endemic regions that include Africa, northeastern South America, and then the Caribbean Basin, as well as southern Japan and Iran. And even in these areas, you find it commonly in areas with a little bit of low social economic status. And then when we look at its historical mapping, we find that it was first described by Sweet in the 1966, and then later on in the 1967, was also linked it to relapsing dermatitis. This relapsing dermatitis, the underlying immune defect, thinking that is one who links now the skin manifestation to immune suppression that comes with HTLV1. And then in the 1990s, that's when you had the first report of the condition associating between the HTLV1 and then infective dermatitis. So that's when the correlation came about. And when you look at, like in this picture I have displayed here, this is how the scalp of the child will look like in case they get this infective dermatitis. They'll get these eczematous eruptions, crusting, edema that commonly covers the scalp, the neck, the axilla, and the groin. Those are the common sites of predilection, and that's how the scalp will look like. Now, look at the scalp, it can even confuse you, thinking that maybe, oh, this may look like scalp psoriasis, or it may look like maybe extensive tinea corporis, or it may look like seborrheic dermatitis. But in this case, it is infective dermatitis, and that's how it will look like. So when you look at the condition further, 2% of patients who have this infection, they're the ones who go ahead actually to develop the infective dermatitis. So that's why I was telling you that you find that up to 90% of the patients who are infected with the HTLV1, they actually are symptomatic. So meaning the remaining 10%, that's where they have the share. The 2% is now going to the infective dermatitis. So the 8% will go to adult T-cell leukemias and lymphoma, and then the other manifestation of this viral infection. And then typically the lesions appear after maternal antibodies have disappeared from the body after 6 months after birth. That's when we expect all the maternal antibodies to be cleared from the baby's system. And then in the clinical features, we see that it will present with the eczematous or exudative crust dermatitis, mainly on the head, neck, scalp, and the groin, as well as the axilla. Then this can be secondary infected with the staph aureus or even the beta hemolytic strep, and possibly it can also complicate with parasitic infections and corneal opacity. So in parasitic infestations, you can have things like scabies or even dermatosis. Then rare persistent into adulthood has been reported, but 40% of the adults with the adult cell leukemia and lymphoma have had a history of infective dermatitis, meaning that when you look at this, if you do a retrospective study and you are looking at patients who have the adult onset T-cell leukemia and lymphoma, the malignancy, you'll find that 40% of them have had infective dermatitis during their childhood. So that is where the correlation started from actually. So when you look at the diagnostic criteria, some people have proposed a particular strict diagnostic criteria for you to make a conclusion that this is infective dermatitis associated with this virus. And in this case, you'll have eczema. You should have eczema of the head and neck region, which includes the scalp, the ears, the eyelid, the margins, and the paranasal skin, as well as the axilla and the groin. So if you have eczema in those areas, then someone has chronic watery nasal discharge, which can actually be similar to what we see in syphilis, in the congenital syphilis, the nasal, the snuffles you see in syphilis. So that continuous drainage from the nose, then someone will get this chronic relapsing dermatitis, which resolves almost spontaneously with the use of antibiotics, but relapses after you've taken out the antibiotics. That is also a major criteria. And then onset is very common in early childhood. And then when you take off blood and someone is seropositive for the human T lymphocyte lymphotropic virus 1, then you are able to conclude that, hey, this patient has infective dermatitis associated with HTLV1. Then in the minor criteria, you can have positive cultures for staph aureus or the beta hemolytic strep from the skin or even the anterior nares. So now we know that this is a common bacteria that usually superinfects this infective dermatitis. Then someone can get a generalized fine papular rash that is put under minor criteria. Then if someone has anemia, elevated erythrocyte sedimentation rate, that the ESR, that usually shows active inflammation, and then they can also hyperimmunoglobulinemia. So this is also put under minor criteria. Another last one under minor criteria is the elevated CD4 and CD8 cell count. And this one will now show you the proliferation that is triggered by the virus. As I told you earlier, upon infection with the HTLV1, it will stimulate proliferation of the T lymphocytes, the B lymphocytes, as well as the monocytes. So if you take off a blood sample and then you're analyzing the cell lines, then you see elevated CD4 and CD8, then you can put this under minor criteria for a diagnosis of HTLV1 associated infective dermatitis. So as I told you earlier, we see this rash, for example, in this article here, a child had this diagnosis because the child had a rash. You see here on the scalp, in the axilla, and then this same child also had a rash, a similar rash in the groin. So that's how it will look like. Then in this other picture, this is how the nasal discharge will look like. Constant fluent discharge from the nose that responds to antibiotic treatment. When you give an antibiotic, it responds. Once you withdraw your antibiotic, the discharge comes back, the rash comes back. And that's when you get now an idea that, hey, I may be dealing with infective dermatitis. So when you take off a biopsy and then you're examining the skin, you'll find that in this case, you'll get a typical lymphocyte within the papillary and mid dermis, if I'm to magnify here. So in this case, though it may not be very clear, but you see all these lymphocytes that show some degree of atypia that will be infiltrating the dermis, especially the papillary dermis, as well as the reticular dermis, with a few of them even infiltrating through the epidermis. Then when you go to this other one, this is a close-up of these lymphocytes that you see on histology. So when it comes to management, in management, the first idea is that you have to prevent transmission with effective control measures. That means that when you take off blood, you have to screen it. And actually, this has been implemented in these countries like Japan, Brazil, Colombia, USA, Canada, that even after you've donated your blood, it has to be screened for the HTLV1 virus. So if it is positive, then that blood is discarded, and no, it is not given to any person. Then we can also do perinatal screening and avoid breastfeeding if the patient is positive. However, in our setting, actually, this is not practicable. So we end up actually just allowing everyone to breastfeed, and maybe later on we deal with the consequences. Because here in our setting, not breastfeeding puts you at a higher risk of death than actually either getting HIV or any other infectious condition from your mother. So that's why for us, we breastfeed, because we know if you don't breastfeed, the malnutrition that comes with it kills the baby faster than what you're trying to prevent. Then practicing safe sex, that is using condom protection and getting off the sexual network, also helps you to prevent. So in case you're treating and someone already has the condition, you can give systemic antibiotics. In this case, you can give a long-term therapy until puberty. In this case, we can use the septrin, that is trimethoprim, sulfamethoxazole, is the one that we prefer in treatment of infective dermatitis. As I told you earlier, it responds very well to antibiotic. But in this case, we choose an antibiotic which can be taken actually for longer periods of time. Then we can also give prophylactic antibiotic therapy, and this can also be used to prevent relapses as well. So if you think that the child is infected, maybe the mother has given them the condition, you can go ahead and give a septrin or the trimethoprim, sulfamethoxazole. Then actually, you've seen us actually even in patients living with HIV, when they give birth to a baby as part of elimination of mother-to-child transmission of HIV, we actually give them Septrin after we've stopped the developing syrup. So this one also helps us to cover also infective dermatitis, assuming that the mother had a dual infection, maybe of HIV and then Htlv1. Then we can also give topical antibiotics like maybe spirocin, and this will help us to clear the skin lesion, as well as we can give emollients to try and moisturize the skin. This will help us to deal with the pruritus that comes with the condition, as well as also provide a relief and calming effect on the skin. Then when it comes to pruritus, you can do mild topical corticosteroids as well as oral antihistamines to try and deal with the pruritus as well. So in terms of screening and follow-up, so for patients that or for individuals that stay in endemic areas and actually have a better healthcare system, this is one of the conditions that is routinely screened, and especially in children. And if you see severe seborrheic dermatitis, it may be an indication that maybe there's immune suppression, so you can end up screening for HIV as well as the Htlv1 virus. Then in continuous follow-ups, usually this is essential to increase the risk, to minimize the risk of complications and to attend to them early, because we know that this virus predisposes someone to developing the adulthood onset leukemia and lymphoma. So you have to continuously follow them through to make sure in case that those leukemia start, you capture them early for better treatment. Then we can also have a regular clinical and neurological evaluation to detect any other signs of parathesias or nerve involvement, because that virus is also associated with parathesias. And then you can also monitor for parasitic infections, because you know that this virus was your immunity against these parasites. So you have to make sure you do the routine deworming and the rest. And you can also continuously follow them through to see if they have high parasitic burdens. Then in public health considerations, you can have things like screening family members and counseling them to reduce transmission, and then identification and treatment to improve the quality of life, and also prevent progression to other immune suppressive diseases that can come with infection of the Htlv1. So thank you very much. Hope this made sense. But in summary, this is one of the viruses that can also cause infections on the skin, though rarely, but it is something that you are supposed to actually know as a practicing skin specialist. So we remember at least, yeah, in adults, it usually causes the adult T-cell leukemia and lymphoma. But a few cases in children, they can end up getting the infective dermatitis, only 2% of them. But this may be a knowledge that you may need to make those clear-cut diagnoses when you're consulted as a specialist. Thank you very much. See you in the next video.